Yes, to share your screen.
Well, you have to share your screen. Okay.
She'll make you a host. That's Cammy's responsibility.
Hold on just a second. Peter, can you help me?
Can you just do it for me?
Dead 3724.
Andy, how you been?
Hey, Stuart, doing well. I like your background. I assume you're actually on the beach and taking time out of your schedule to hang out with us this evening.
Yeah, let's go with that.
Yeah, because I know that's what I would be doing if I were on a sunny beach with the palm trees blowing in the background like that.
No,
So,
unfortunately, I'm at the office. I have one more patient to see. So it's just my Zoom background. That's all.
So tonight we're gonna dive into Infuse. It's pretty cool, actually. You know, a few positive things from COVID that normally Bausch won't let us have local speakers in local events, which I disagree with.
Who's talking?
I think we have 9 pages of people. So
Hey, Andy, how was golf a few weeks ago?
I decided to go get a COVID test instead of play golf. So it didn't really happen.
Oh, okay. I had to get I went on a trip with a bunch of guys 2 weeks ago to Kentucky, and 2 guys came down with COVID. I had my COVID test last Friday, negative,
Yeah.
but 2 of the 8 guys came out positive.
All right, there's some handsome people out there. I think we're at 7. How about we give it, well, let's go ahead and be on time. This will be something new for us. Obviously, John, show me you can hear me. Everybody can hear me. All right, well, welcome to our continuing education. We really like having you guys come to our office and be our guest there, but being the situation that it is, and we're all getting very used to Zoom meetings. My computer went right to the Zoom app and it was easy. So welcome, we're glad you're here. A couple of announcements. It looks like most of you have muted your microphones, and that'd be great so that we don't have any extra background noise. A couple of announcements. Well, the first one is that you may have heard by now, but Moyes Eye Center has acquired John Reifschneider's practice in Leavenworth. And we've been talking to John for quite a while. And we're very excited about that. So that gives us a third major location, and we're excited to pursue that and be available for referrals on the Kansas side of the line as well. So our next announcement is this is a chance you guys are going to really enjoy meeting Lindsey McDaniel. Lindsey joined the practice with us about the 1st of September. Lindsey is a glaucoma and cataract specialist. She trained, this will make at least half the crowd very happy, at Mizzou for college, medical school, no, not college, a medical school residency and fellowship. She just finished her glaucoma fellowship there. And I'll be honest, it's been great having Lindsey with us. Lindsey is very bright, very capable, and also very energetic at pursuing things. So we've been really pleased. So Lindsey will be our first speaker tonight, and she's going to be talking about primary open-angle glaucoma, obviously what we see the most of. And I think you guys are in for a real treat. And on that note, Lindsey, it's all yours.
All right. Are you guys able to hear me? Andy, are you able to hear me? Okay, great. So we are, forgive me, I don't share my screen often, so let me know if there's any issues. Peter's right here to help, thankfully. I'm Lindsey McDaniel. I am coming here from Columbia, so not too far down the highway, but I've got a presentation for you guys today. And are you guys able to see just the PowerPoint or my whole desktop? Andy, are you seeing just the PowerPoint?
I see you, and then I see it's not on the slideshow. It's on the screen sorter view right now. Okay. I don't see the rest there. I think that's good, better.
Perfect. If it's not, let me know. So we're talking about a couple different things today. So primary angle closure, and I'll keep an eye on the time. So I know nobody wants to go up their entire night to glaucoma. I don't blame you. So I'll keep an eye on that and then give plenty of time for Dr. Chappell to also give his talk. He's talking about Botox, so also very exciting. So there was something that we see a lot that's kind of often misclassified, or people aren't sure what to do, and there's just kind of some changing information about it. And so I thought I'd just go over the AAO preferred practice patterns with that. So small agenda, angle closure, talking about just the guidelines and kind of where we go from there, talking about the Eagle study, the light trial, and then I had a couple of interesting cases. So once I was asked to do this study, I was excited to try to get to know everybody. It's such a weird time. I have gotten to know several of the referring optometrists, which has been great, but COVID obviously makes that very challenging. So it's hard to go door to door. I've done that with a couple of people, and then have also had the chance to meet socially distanced with a couple other people. So hopefully after all this ends, I'll get the chance to meet all of you guys. It's just a little bit of a weird time. So in thinking about my agenda for the night, I wondered how I would keep everyone's attention talking about angle closure. And to be honest, I wasn't sure. So I saw this and I was like, it seemed so appropriate for how the night may go. So we'll see if this works.
Good morning. Okay, I think we're all here. I see Jimmy and Clyde are on now. Eric, are you there? Yes, teacher, I'm here. I can't wait to start skip. Oh no, Eric, I think your computer is freezing up again. Oh no, really? Can you guys hear me? I just said Eric, you'll just have to listen again, okay? Best you can. So let's start today, guys, by going over yesterday's grammar examples. Wendy, can you read the first one?
So I saw that on the special of South Park, and I thought that was very interesting and very representative of how this evening could go. So I decided to switch the agenda up and try to keep your attention a little bit more and talk about a little bit of glaucoma what ifs and just talk about kind of our approach to glaucoma a little bit and incorporate the light trial, the Eagle study, which are new trials in glaucoma, some new guidelines, and then discuss angle closure, and if we have time, some interesting cases. So a couple of what ifs to start out with. Glaucoma is an ever-changing field, and especially recently with the era of MIGS, and tons of research, tons of new things coming out that sometimes hard to keep up with. And what do we do? And so just kind of some talking points for everyone to think about. So what if we recognize glaucoma as a surgical disease? And so that I'll be working tonight to build that case for you, that it is more of a surgical disease and there are things that we can do. What if I told you that there are now options in glaucoma? Again, exciting. We now do have options in glaucoma. we have MIGs, we have lasers, we have all sorts of things that we can treat glaucoma, and we can treat it early and prevent it from getting as bad as it has. So it doesn't have to be this scary, feared disease. We can keep kind of keep tabs on it. And also, before I forget, Cami asked me, for all of you guys who are logged in, if you could change your name to your first name and last initial so that she can give you guys credit for logging in. Some of the names are screen names or whatever else. So she wanted everyone to log in with their first name and last name, or at least their last initial, so she knows who all's logged in, and that way everyone gets credit. What if we thought of glaucoma treatment in a proactive way as opposed to a reactive way? So up until recently, I feel like we've dealt with glaucoma in a very reactive way. We kind of watch the visual fields, we watch the OCTs, we see a slight progression here, a slight progression there, and then we're chasing our tails. And I feel like up until recently, it has been kind of something nobody wants to deal with because of that. All of a sudden, someone has 3 ganglion cells, and then we're going to try to treat it. And that's hard. So we now have different options. And what if we could avoid that? Cataracts are the #1 leading cause of blindness worldwide, and glaucoma is #3. So that we now have options, and we can I think we can do better with that. What if we saw visual field progression as the exception and not the rule? So what if we lived in a world where we could prevent that, where we act early, we act often, and we prevent the visual field progression before it happens, as opposed to reacting once we see that loss? If that were to happen, then I could retire. Too soon? All right. So to take this a little more personally, what if I told you that you had open angle glaucoma and you had the choice to do SLT versus drops? How many of you would choose SLT? How many of you would choose drops? I know most of you are muted, so I'll just keep going. I feel like a lot of people say, why would we do a laser? Patients are hesitant to do laser because drops are benign, right? Here we have a lovely picture of prostaglandin orbitopathy. Got severe orbitopathy with MGD, erythematous eyelid margins, upper and lower lid fat atrophy, chronic chalazion of that right upper lid, all from that prostaglandin. Bromonidine, we see red, irritated eyes. A lot of people can't tolerate it, but they still try, and they're miserable with it, but they're more concerned about losing vision. We've got bromonidine KP, also not fun. We've got Rhopressa verticillata, or vortex keratopathy, often benign, but it looks terrible. So what if I told you there was a light trial that kind of steers us away from that? This was a randomized controlled trial of 718 treatment-naive patients with open-angle glaucoma or ocular hypertension, randomized to drops or SLT. It looks at the quality of life, visual acuity, IOP, and it looks at this over 3 years. So then think about that question: which would you prefer if I told you that 74% of SLT patients remain drop-free at 3 years, and they had better IOP control at each visit, and less secondary surgery, and less disease progression? Would you still aim for drops? And so I talk to patients about this, and I tell them that, you know, there are options. We have lasers, we have drops. I think some people are hesitant when you say laser surgery because they think it's a big surgery. But you look at these numbers and it's hard to argue with. I feel like oftentimes in residency, we were called eye dentists as ophthalmology. And you can kind of compare that with when you go to the dentist and they ask you if you floss every night. Of course you say yes. So when our patients come in, you say, are you using your drops every day? Of course they say yes. And you're like, well, that's interesting because your pressure is 12 today, but you have significant visual field progression. Like, are you sure you use them every day? And so I tell them, like, this is a safe space. I want you to let me know if you're actually using them or you're not. If you're not using them, coming here and telling me you are is not helpful, because you're still going to end up with glaucomatous progression. We're going to wonder why. So if it's not working for you, let's say it's not working for you and find an alternative. So I think this is a great option and it's shown to be effective. And then recently, in ophthalmology, this was published, which I also thought was interesting. It was published in April, and then AAO published kind of a recap here in October. And it shows that a greater proportion of eyes underwent moderate or fast total deviation progression in the medical therapy group compared with the SLT group. A greater proportion of point-wise pattern deviation rates were categorized as moderate or fast in the medical therapy group. And overall, they concluded that slightly larger proportion of ocular hypertension and glaucoma patients treated with medical therapy first underwent rapid visual field progression compared with those first treated with SLT. So I point this out because we do see a lot of SLT consults, which is great. But I point this out because I think we could do this sooner. I think when we start a medication, we could offer them that you could do SLT first instead of starting that medication, or instead of adding that second medication, you could do SLT. I feel like we often see this once they're on 2, maybe 3 classes, once it's pretty severe. And at that point, I don't think SLT is enough for them. So I don't think it's certainly not going to hurt. And I think it is a great option at that point as well, but I think they need more. And so I think this is a great first step as opposed to a 4th step or a 5th step. So I want to just kind of point that out to everybody. The next what if I told you that you had angle closure glaucoma, your vision was still 20/20 uncorrected, and you needed cataract surgery instead of LPI? Would anyone be for that? Would anyone be against that? And I say glaucoma here, you have angle closure glaucoma because there's evidence of optic nerve damage or elevated IOP, not because you have narrow angles. And so that's kind of the distinction in the EAGLE trial. So the EAGLE study compared primary clear lens extraction. And so some of these patients may not have been completely clear, but essentially clear for primary angle closure and primary angle closure glaucoma. So primary angle closure suspect was not studied in this. They did have to have that component of some sort of glaucomatous damage, whether that was PAS, whether that was elevation in IOP. But looking at the data, the clear lens extraction showed a greater efficacy, spelled terribly wrong, and was more cost effective than an LPI overall. Should be considered as a first line therapy. So when we look at this, we look at the clear lens extraction, any additional glaucoma surgeries, we often say that lens extraction or cataract surgery is the first glaucoma procedure. And I think this is kind of the basis of that. By taking that lens out, we're creating more space. We're opening up the angle and allowing the angle to work more effectively. So I think a lot of people consider that the first glaucoma procedure. When we look at additional procedures needed, we see that 16 of the 24 additional procedures in the LPI group were cataract extraction. So they ended up there anyways. 6 of those were TRABs, which we know are not side effect free. And this kind of tells us that we're moving away from endpoints of just looking at IOP and looking at, are we needing secondary procedures? Are we seeing disease progression? And looking at other outcomes as opposed to, are we just lowering the IOP? Because we can lower the IOP, but if that lens is still in there and the angle is still closed, long-term, it's going to be ineffective. If the angle doesn't open up, the trabecular meshwork shuts down and it's not going to be effective long-term. So I think LPIs certainly have a place in younger patients that still have accommodation. Of course, we don't want to take their natural lens and get rid of their accommodation. But in an older patient who's kind of borderline on the kind of on the edge of needing cataract surgery anyways, maybe it's not as effective. And this tells us that. If there's any PAS, I'm also very hesitant to do it because any inflammation from that LPI can zipper the rest of the angle closed. So I'm also hesitant to do that in that point. There are risks with an LPI. You can end up with persistent photopsias afterwards, where light can come through that LPI, persistent inflammation, IOP spikes, or maybe it's just not effective. So ultimately, I think we need to consider the whole patient and what we're looking at. A lot of these patients are hyperopic and their eye is just too small. And so taking that lens, if they have any component of that phacomorphic angle closure, ultimately they just don't have enough room, and the solution is going to be to take the lens. And so I try to balance that before offering LPI. If they're going to need lens extraction or cataract surgery in the near future anyways, my preference is to just do that and spare them the procedure of an LPI. And that comes from this study. What if, the next one, this might be the last one, I told you that you had open angle glaucoma and you need a TRAB. So we have these nice ischemic blebs. We have possible blebitis on this portion. Or maybe I told you need a tube. We've got exposure of the plate, got sutures exposed here. I show these photos because these aren't without complications. These can be done beautifully. Dr. Bettis does a beautiful TRAB. Tubes are great, but not everyone needs them. And so I don't think this needs to be the only tool in our pocket because they're not without side effects. These typically are considered the bigger glaucoma procedures. And so I don't say that lightly. So if I told you you needed a tube or a TRAB, would you be this excited? When we look at this guy, he's got a nice hyperencapsulated infranasal bleb with a little vertical strabismus at the very least. And so I say that, again, not every tube looks like this, of course. They certainly have a time and place, but I don't think that this should be our first or our only option. So the intervention that we have available changes our threshold to intervene. So the lower the risk and the more effective the procedure, the higher our intervention rate typically is. If the risk is low and it's mildly effective, we typically intervene earlier, but maybe not to as many people. If it's high risk, even despite it being very effective, for example, a TRAB, oftentimes we wait until the disease is very severe. And that exact patient may not be able to tolerate it because then your risks are higher, and that patient who has reganglion cells left might not be able to tolerate any hypotony that might come with these bigger procedures. So I think that's important to just look that we have other options that we can intervene sooner. When it comes to MIGS, I think some people have the mindset that it's impossible and it won't work. We've tried that, it didn't work. There certainly are MIGS or minimally invasive procedures that we have tried that haven't worked. But we tried, and those patients are still getting care. That potentially worked for them at some point. Perhaps they need something later on, but it did work for some period of time. And they don't have the side effects of some of those bigger procedures. So I feel like we need to get rid of that mindset and look to glaucoma as a surgical disease, intervene early and intervene often, because a lot of these have lower side effect profiles. And so they're fine to try earlier. I feel like any patient who undergoes cataract surgery, if they're on a committed glaucoma therapy, they should be aware that there's other procedures that exist that may help make them independent of those medications, because as we talked about, those medications aren't always benign. So we look at it kind of like a station wagon. Hold on, I don't know how to go back there. So in the front, I feel like we have the glaucoma doctors, like as pretty aggressive, kind of leading, saying, let's get out there, let's do more glaucoma surgery, let's treat it early, let's treat it often. In the middle, I feel like we have most everyone else saying, we like where things are headed, this all looks good, kind of waiting to see what comes of some of these mixed devices. I see what you're saying. I want to encourage you guys to keep going, but we're kind of along for the ride, and we'll see where this goes. Once we have a little more concrete evidence, maybe we'll hop on board. And then in the back, we've got people watching the road going beneath them, complaining that there's, about where we're heading. Glaucoma is terrible and we have nothing behind it. I think this backseat group is minimal. I think is great. I think people are kind of moving and appreciating MIGS a little bit more than even when I started residency. I feel like there were all sorts of acronyms and people had their own abbreviations for what MIGS stood for, oftentimes not great. But I think we are moving in the right direction. And I think that's important to look at and just see that we're heading in the right direction and we're finding new things and we're trying more. I don't think we're there yet because obviously we're seeing visual field progression, but I think we're doing better. We have more options and we have a better tool belt to provide to these patients for what they're looking for. Some of those options, this just kind of looks kind of a really busy slide, but just basically shows that we have a lot of different options. So technically MIGS, minimally invasive or microinvasive glaucoma surgery. There's AB internal approaches, there's AB external approaches. There's potential advantages to this. There's minimal tissue trauma. And this leaves the conjunctiva and other areas of the eye for bigger procedures should they need them down the road, which is great. It's neutral reactive state. Efficacy is moderate, is modest. So perhaps it's not as effective as a TRAB or potentially a tube, but the side effects are also less. And so with that efficacy being modest, not every patient needs a tube or a TRAB. And so that modest efficacy is fine for a lot of people. Overall safe, recovery is pretty rapid, and there's multiple ways in which this can happen. So these glaucoma procedures all share certain traits. They don't disrupt the conj, so traditional surgeries can be performed if they need to. Overall effective, and they should avoid serious complications. Again, yeah, so data's coming in that maybe they're not as effective as a TRAB, but again, everyone doesn't need a TRAB. Caveat to that, there are some people that still do. We can't get away from that. And we still see people that need single digit pressures and the TRAB is perfect for them. So the point of this is kind of to show that we need to realize who needs that and who doesn't and try to treat early and know what we're treating. So for example, a GAT, we looked at a retrospective chart review, 24 months, and it had very good effects with primary open angle glaucoma, but better pressure lowering effects with secondary open angle glaucoma. So what we get from that is we want to know the mechanism of the glaucoma that we're treating and tailor our treatment to what that is, of what's causing the elevation in pressure. We also have non-surgical options. There's power in the uveoscleral route. There's multiple injections that are coming out of PGAs with sustained released that have been shown to lower IOP for over a year from the last injection. This is still in the really early phase. We're doing 2 studies here, Triton and iDose. One has a biodegradable implant and one has an injectable titanium stent. I'm excited about these just because we do see people, like I mentioned earlier, who don't floss every day and they're not using their medication every day, or they can't use it every day. Whether it's a kid who's too busy and just can't remember, to an elderly individual with RA and can't use drops. There's all sorts of people that, you know, whether it's because they don't feel like using it or because they really can't, they're not getting the solution that we're providing for them. So I think this is another tool that we can put in our tool belt. And I think that's another great option. So I'm excited to see kind of what comes of these. So the take home from the first part is that glaucoma is a surgical disease. And I hope we start thinking about it as such, that we can treat it early and treat it often. We have tons of options and options for any patient that comes in. I always tell patients that glaucoma is just as much of an art as it is a science. And just because one thing worked for one person doesn't mean that that's the solution to their problem. So I try to work with them to figure out what works with their lifestyle and what works with what they're able to do and their goals of care, and figure out a treatment plan that works for them and keeps their glaucoma from progressing. Not everyone needs a sledgehammer, but some people do. So we always have that as an option. But I hate to think of that as our only option. So I just kind of wanted to point out that we have tons of options, and then encourage everyone to be proactive rather than retroactive. So if there is a patient on one drop, we can discuss SLT. We can discuss other options before it progresses, as opposed to chasing our tail once we get there. How are you doing on time? Okay, I'll try to run through this pretty quick, and then we can get through Dr. Chappell's talk as well. So angle closure glaucoma, this was something that we talked about in our clinic. Just some basic kind of terminology. They just updated the BCSC book for ophthalmology. It's just a little bit more descriptive than narrow angle glaucoma or narrow angles, anatomic narrow angles. It just gives us a little bit more information about what's going on with that specific patient. So when someone comes in with narrow angles, what do we know? That they have a risk factor for angle closure glaucoma. What do we need to know? Is how we arrived at that. Was it based on gonio? Was it von Herrick? Was it an IOL master, lens star? Are they symptomatic? Do they have risk factors? And how acute is this concern? So our job is basically to figure that out and better classify them, to risk stratify them. So the current narrow angle verbiage is primary angle closure suspect, primary angle closure glaucoma, acute angle closure crisis, Plateau Iris configuration, Plateau Iris syndrome. So real quick, we'll kind of go through those. PACS is greater than 180 degrees of iridotrabecular contact with a normal IOP and no PAS, therefore no glaucomatous damage, no optic nerve damage. Essentially narrow angles without glaucoma. This has an unclear risk of progression. One study shows that 1/4 of people developed some symptom of optic nerve damage within 5 years, but not a great, the N was small, so we don't really know. At this point, we're suspicious of these patients. Primary angle closure is greater than 180 degrees of iridotrabecular contact with PAS or an elevated IOP, but still no optic neuropathy. So this persistent ITC is noted to cause permanent histopathological changes to the eye. And at this point, we need to treat because we're well on our way to glaucomatous damage, again, which we're trying to prevent. Once there's primary angle closure glaucoma, we're seeing that evidence of optic neuropathy. And so this is seen as glaucomatous RNFL thinning or reliable and reproducible visual field progression. So kind of the definition by which we classify optic neuropathy secondary to glaucoma is based on this definition from AAO. Chronic progressive optic neuropathy in adults in which there's characteristic acquired atrophy of the optic nerve and loss of their retinal ganglion cells and their axons with an open angle. So we still use these characteristics, but then apply them when the angle is no longer open. And then angle closure crisis, what we all try to prevent. Occluded angle with symptomatic high OP, hot red eye, elevated pressure, vascular congestion, headache, nausea, vomiting. At that point, it's an emergency. OCT is not really necessary during acute angle closure. Once they've had acute angle closure, I don't think there really is like a baseline OCT because you're getting swelling immediately. They say back to normal, but what is normal at that point? Around 1 month, and then you'll see the atrophy around 3 months. This can resolve, but can recur. And we see permanent vision loss or blindness that can result if untreated. We want to look here at the second eye. So if the first eye has acute angle closure crisis, we want to prevent that in the second eye. And then Plateau Iris is more of a configuration that it appears peripherally closed, but deep centrally, and that differentiates from acute angle closure. I'm gonna try to speed through some of this. I know we're kind of running out of time. So the scope of the problem is larger. So 0.7% of the global population over the age of 40 is estimated to have angle closure glaucoma as of 2013. So it's not a small number of people that are developing this. So I think it's important for us to be able to identify this, at least identify risk factors for this and risk stratify our patients so we don't lose them and end up with acute angle closure. Risk factors for angle closure: Asian descent, hyperopia, so just overall a smaller eye, axial hyperopia, older age, female gender, a shorter axial length, size, shape, position of their crystalline lens. If they have an anterior position of that lens, also a higher risk, and steep corneal curvature. What we want to look for if they're coming for angle closure: blurred vision, halos, eye pain, family history, and then also discuss any other causes for a shallow AC, whether they have new meds that may cause ciliary body edema, sulfonamides, topiramate, anticholinergic effects. Look for a hyperopic refractive status if they have a short eye, if they have a narrow anterior chamber or a shallow anterior chamber, if their pupil is mid-dilated, not reactive, they have an RAPD. All of these things are signs of acute angle closure. When we talk about a differential for this, so if we see this, we don't want to assume that the patient is an angle that has narrow angles. We want to consider other things as well. PAC and PACS are often bilateral. So if the other eye is wide open, consider something else. Maybe there's something pushing from behind. Maybe there's a mass pushing the lens forward. But think of something else because it's not symmetric. Pulling mechanism, secondary angle closure for iris membranes, so NVI, epi downgrowth, ICE, something like that. Or a pushing mechanism, secondary pupil block, uveitis, iris bombay, lens related, whether there's a retinal condition causing ciliary body swelling, pushing the lens iris diaphragm forward, or aqueous misdirection. When we see these people, we hate to dilate. Are we going to put them into angle closure? Are we not? So how can we evaluate whether or not they're safe to dilate? We can look at von Herrick, which is quick and non-invasive, but also very subjective and hard to reproduce. This only looks at the temporal angle, which leaves us with 270 degrees that we're not sure. And it's also dependent on the corneal thickness because you're kind of basing that ratio on the corneal thickness to the anterior chamber depth. So if the cornea is really thick, the AC may be normal, but it appears shallow, and vice versa. If you have a really thin cornea, you may say, hey, this is wide open, but really it's not. Gonioscopy is the gold standard, and our definitions are based on the findings of this. We have to be careful because compression, while they can break an acute attack, they can also give variable results. If you're compressing during normal gonioscopy, you may be seeing a more open angle than really exists. So you want a dark room, a bright, short light to avoid inducing any meiosis, which can also kind of pull that angle open. For narrow angles that are hard to see, we wonder, do they just have really pale TM that I'm not seeing? Or are they actually closed and I'm not able to see any structures? You can have the patient look towards the mirror of the gonioprism in which the examiner is looking, and that kind of helps you to look down the angle and get a little bit better view if there's any structures to see. On anterior segment imaging, this helps to identify plateau iris, iris bombay, complete angle closure. I know Dr. Bettis and I talk frequently that, this is something that is not done infrequently to say, is it open, is it not? In real life, our anterior segment OCTs aren't looking like this. And so it's really hard, where here we can see the scleral spur clearly identified on the OCT. In real life, we don't see that. So gonioscopy is still much better than what we're seeing there. We can look at an IOL master. And so we would use this in residency sometimes to see if an LPI may be beneficial. And this wasn't studied, it wasn't published, but it seemed to work for us there. And so our normal lens values, our normal values, the lens thickness is normally about 4.7 millimeters, axial length 22 to 25, AC depth is 3. And so what would be concerning for us to look for would be a lens thickness over 5. We would say that regardless of an LPI, there's a lot of lens there, and an LPI may not be beneficial. An axial length of less than 21, again, a really short eye and just not a lot of room for that lens to grow. An ACD of less than 2, some people say 2.5 millimeters, but you're getting pretty shallow and at much higher risk for angle closure. Provocative testing, largely replaced by gonioscopic exam and just looking at the clinical findings. Overall, you're unlikely to provoke an acute attack, but if you're suspicious, it never hurts to refer. I mean, in a retina clinic, they don't gonio, and I don't think they send many people into angle closure, and they dilate everyone. So I have to believe that it's rather uncommon, but if you are concerned, feel free to send them over, because the best place to have angle closure is in a glaucoma clinic. So we're happy to do it and see if it works. Sometimes if there's narrow angles, we're happy to dilate for you guys and then send them back, just to make sure that we don't see an elevated pressure after we dilate, and then kind of have that peace of mind that if it were to happen, it happens in a safe place where we can treat it. So we're happy to do that. So we want to preserve visual function, maintain quality of life, control IOP, and reverse or prevent any angle closure processes that we can. Glaucoma screening is covered by Medicare, so also great for us to do. I think we're running short on time a little bit. Let me know if we're like really running out. So we kind of covered this. If it's PACS, we can consider an LPI if it's a really young person. If they're an older person, sometimes better to keep an eye on it. And then cataract surgery may be their better option. For PAC, LPI is historically indicated, but again, the EAGLE study shows us that primary lens extraction may actually be the more beneficial option. So we talked about that earlier, kind of reordered some of these slides last minute. And then acute angle closure. Thankfully, we don't see this a ton, but when we do, we want to lower the IOP, kind of dump all of the medications that we can on these people. Try compression gonioscopy. Sometimes you can break that acute attack. Consider an LPI if the cornea is clear to bypass that pupillary block, but it won't help if true appositional angle closure is present. You can do a PI or a paracentesis. And then ultimately, they typically need phaco and goniosyneciolysis. And again, like we mentioned, evaluate the other eye. 40% of acute angle closure develop acute angle closure in the other eye within 5 years. So you can consider a prophylactic LPI or a prophylactic lens exchange or lens extraction in the other eye, kind of based on their risk factors, their age, and other characteristics of that patient. Billing and coding, there are codes for all of these things that we just talked about. So you can bill for each of these diagnoses, and then they come up kind of on your charts and just help to better risk stratify these patients and just help everyone kind of know where they stand as opposed to just narrow angles. These tell us a whole lot more about the patients and what their risk factors are. For staging, we code by type, and then we add the stage. We determine the severity in the worst eye, and then look at optic nerve abnormalities consistent with glaucoma. Mild or early is no visual field defects. And this is from kind of the coding. I know everyone has their different standards and how they decide what stage it is, but based on AO, this is kind of what they go by. Moderate would be visual field defects in one hemifield and not within 5 degrees of fixation. Severe would be visual field defect in both hemifields and or loss within 5 degrees of fixation of at least one hemifield. Indeterminate, either you don't have a field or they're incapable of producing a reliable field, so we just don't know. And unspecified is just not recorded. So insurance is starting to deny this, so it's better to put indeterminate than unspecified. So I'm new to Kansas City, so I thought I would just kind of introduce myself a little bit. Clearly a Mizzou fan, as I'm sure all of the rest of you are. Zip code is just a number. Also a Cardinals fan, so I know some people got confused when the Royals won the World Series a couple years ago. We saw a little more blue in Columbia, but my whole family we are diehard Cardinals fans, so that won't change. This is my little niece, Lena, my sister's little girl, who's just super cute. My sister and my mom still live in Columbia. And then this is my dog, Chevy. This is Marty, the other half. So I know Moise has had a little bit of some mother-in-law syndrome. So it's not infrequent that I get the question of, why are you here? And are you gonna stay? So I thought I would introduce him. So he's been in Kansas City a lot longer than I have. He is up for partner at his firm in March. So there should be no moving for us anytime soon. This is my family. So this is in Columbia at the Magic Tree. This is also my cousin. He's him and his now 5 kids live in Overland Park, and he's a cardiologist there. So just a little bit about me and my family and kind of where I came from. Since I can't meet you guys in person because of COVID, I thought I would just introduce briefly and say thank you for tuning in. So if anyone has any questions, please let me know. We've still got a great talk about Botox coming up. Dr. Chappell has a wonderful talk. I know he has a lot of videos, so we thought that may be a little more interesting than angle closure. So we let him kind of come in at the end to leave you with something a little more exciting. So does anyone have any questions? Those are my favorite kind of questions. All right.
Lindsey, first of all, let me say, you did what an excellent talk. You covered a lot of ground, and that was, you did a really, really good job. What's fascinating to me is how the change of treatment of angle closure has changed over the last 5 years with the Eagle study. It was like 5 years ago, it felt like it was very aggressive to do lensectomy, but the more I look at the data you put out there, it really is in the patient's best interest to do a lensectomy early. And I liked your distinction of, obviously, if they're not a presbyope yet, that's a really mean thing to do, to take someone who's accommodating and making an instant presbyope. So
yeah. So I think it's great. I mean, you just have to look at every person and see what's best for them. But it's not infrequent that you see people with persistent photopsias or have inflammation from the LPI and ultimately need the lensectomy anyways. So I think you just have to look at everyone independently and see what's best for them. But I think this data makes a strong case that if they're going to need it anyways, why not do it first?
That's great. Any other questions from anybody? Unmute and ask. Well, if not,
right.
Lindsey, I'll say excellent. I learned a lot. I think everybody learned a lot. That was really well done. Lindsey is available for consultation at our main North location, at Lee Summit, and in Chillicothe and Trenton. And again, obviously, our anterior segment specialists are not just glaucoma, but excellent cataract surgeon. Practices cataract and glaucoma care. So thank you, Lindsey. At this point, it will do me great good to get that Mizzou picture off of the screen.
That was just for you.
Okay. I wore a Jayhawk pullover to the office just for Lindsay the other day.
Yeah, on my interview, actually.
Oh,
And
yeah.
I still came. Yeah.
I did. Yeah. And Ryan, I saw your ZOU, and I would never let my children, though I live in Missouri, go to a school that spells Missouri with a Z, an A, or an H. So that's just all I'm saying. All right, next up is Michael Chappell. I think most of you guys have had a chance to meet Michael. Michael's been with us a little over a year. Those of you who met him know he's just a prince of a human being. It's been a lot of fun to work with Michael. He's got a great fund of knowledge. He's a very bright ophthalmologist, and patients. Oh gosh, now you're listening to me. Patients love him, and he's just done a great job of taking care of people, all the way from very complex oculoplastics diseases to he has a very real interest in the cosmetic side today. And Botox kind of straddles both sides of that equation. I think you're going to talk more about the cosmetic side of it today. One other announcement on our acquiring the Leavenworth practice is with that, Dan Bettis is taking the lead of being our main surgeon at the Leavenworth location. Dr. Reifschneider is still working and seeing patients there too, but is really looking forward to retiring. So, but Dan will be seeing glaucoma consults, cataract consults at our North location, as well as our Leavenworth location. On that, Michael, teach us about Botox.
Great. I was just instructed that we're going to give just a few-minute break, maybe a 5-minute break. So I'm going to dim my screen. It's 7:49 right now. Why don't I start at 7:55? Everybody will take a quick break, and then we'll come back and learn a little bit about botulinum toxin. So I'm going to start at 7:55. Great. Thanks. Okay, I've got 7:55 on my clock. We'll start getting going again if everybody can hear me. Hopefully we'll get going with everything. I'm Michael Chappell. I've been at Moyes Eye Center for about a year. It's been a wonderful year. I got to talk to some of you last year at some of these events. I really appreciate your referrals and letting me help take care of some of these patients. A couple of announcements real quick. Again, if you are hoping to get some credits for being part of this discussion tonight, please change your screen name on the Zoom account to your first and last name both. That way Cami can help arrange everything for you guys to get your credits. I want to give a shout out to Cami Evans, who's our outreach coordinator, who's doing a fantastic job of getting this organized under these strange circumstances that we're all dealing with, but thank you so much for your help. If anybody has any questions about any of the topics we're going to talk about, feel free to add that into you're welcome to jump in anytime and ask any questions, or you can use the text to ask me any questions. And so we'll get going with this so we can get on with our evening. So let me arrange this. I think we'll be able to set this up. All right, so get through these, make sure okay, perfect. What we're talking about tonight is botulinum toxin, and we're talking about historical perspectives and modern clinical uses. And this is designed to be an overview for you folks, for the eye care providers. In the last few decades, botulinum toxin has grown from only being utilized by a few researchers into something that is used to treat over 7 million Americans a year. And it's a multi-billion-dollar a year industry. Patients seeking or requiring these injections are really commonly seen in all of our practices, even if you don't know it yet. So the purpose of this talk is to discuss the origins of the medical community's understanding of the toxin, and also how it can be utilized for medical and for cosmetic purposes. We're going to talk about both of those things. My purpose of this is not to be a sales talk. I'm not advertising one of these products versus anything else. But better to have more importantly, to have a better understanding of how commonly these things are used. So there's a lot of different types of, sorry, I'll get into that in a second. Here's our contact information for our couple of our offices. The bottom of this is my personal email and also my cell phone number. Please feel free to reach out to me anytime with any questions about this presentation, about any patient care issues. I actually got a text from a doctor today asking a question about botulinum toxin. So it fit very well with what we're going to be talking about tonight. So you're welcome to have this anytime. Please call or text with any questions if I can ever be useful. There are no financial disclosures in this. I want to put this in here so that you understand that I'm not trying to sell any of these products. I am going to be talking about some brand names of the different botulinum toxins. Botox is the most common known of these toxins, and Botox has sort of become the common name for all of these, sort of like Xerox or Kleenex. So you may find me saying Botox when I'm actually meaning botulinum toxin in general, so I apologize in advance for that. And then I'm also going to be talking about some off-label uses of these toxins. I'll specify when I'm doing that later so you have a good understanding of what we're dealing with. Let's keep going with our slides. Okay, so here's a little overview of what we're going to be talking about. I'm a history nerd, so I apologize in advance for that, but we are going to talk about some history of our understanding of botulinum toxin and also the mechanism of its action. We're going to talk about the different formulations and the dosing forms. We're going to talk about the medical indications for these different toxins and the cosmetic indications. So we're going to get through that in a short amount of time. And I'll try not to take too much of your evening. Thank you so much for giving me time this evening. Because oculoplastics covers oculofacial plastic and reconstructive surgery, what I do, because this covers various regions of the eyelids and face, the injection of botulinum toxin has become an increasingly common and important part of my practice. And here are the main medical reasons why we do this. And we're going to talk about each of these individually as time goes on here. Myokymia, benign essential blepharospasm, and hemifacial spasm. And then we're going to talk a little bit about the cosmetic injections we do as well. Let's talk a little bit about the mechanism here. Botulinum toxin is a naturally derived chemical that's made by the bacteria Clostridium botulinum. The way it works is it prevents the release of the neurotransmitter acetylcholine from the neuromuscular junction. This causes a flaccid paralysis of the muscles. The way this works is it's a highly specific but reversible inhibition of the presynaptic acetylcholine release. it inhibits the exocytotic mechanism within these neurons. So basically the neuron itself does not spit out acetylcholine to the muscle. So by blocking this vesicle binding to the cell membrane, the acetylcholine is not released and the muscle does not contract. So this is a little diagram showing this. And basically by having that botulinum toxin in there, it keeps those vesicles from binding. This is a slide actually from the company Botox. To think about this in a little modified way, but if you have botulinum toxin injected to tissues, it cleaves one of the proteins that helps receive the vesicle of the acetylcholine. And so that vesicle can't bind. So basically the nerve cannot send a signal to the muscle to contract. That is as nerdy and scientific as we will get tonight. So I apologize, but I think it's a really interesting way to understand how this medicine works. And it's amazing how much this has blown up in the last 30 years. So this got FDA approved in 1989. And since then, it's now grown to be used by, like I said earlier, 7 million Americans a year get these injections. And there's a lot of conditions that are now FDA approved to be, FDA approved indications for the different types of toxins. And we'll talk some about these. Obviously, we're going to pay more attention to the ones that we see as eye care providers, but it is important to know that there's increasing amounts of FDA-approved indications for these things. And then, of course, we also know that these things are used to treat wrinkles as well. And that's what people come to me saying is, you know, I was told I need some of these injections, but I don't want to look like one of those crazy Hollywood people. So we'll get into talking about that a little bit later too. I mentioned earlier that I'm a history nerd, and because of that, I'm going to talk just for a couple minutes about the history of our understanding of this toxin, because I think it really sheds light on how we think about this and how we use it today. And as crazy as it is, as early as the 10th century, there's written evidence of that consumption of blood sausages leading to these poisonings. And the poisonings we're talking about is leading to paralysis and death. We now know this to be botulism or botulinum toxin ingestion and poisoning. But this was banned by the Emperor of Byzantium in the 10th century. Here's a picture of this guy, Leo the Wise, and this is from the Hagia Sophia in Turkey. But then through the 18th, 19th centuries through Europe, there were a number of outbreaks of these kind of poisonings that we now know are caused by botulism. And some of these things are related to eating of blood sausages in Germany and Central Europe. I didn't know what blood sausage was. Here's a picture I found. It looks delicious. But these patients have lots of symptoms, but gastrointestinal problems, diplopia, mydriasis. And then really interesting guy in 1820, this is a German researcher, physician, and biologist who looked at 76 patients who had similar symptoms. No one knew what was causing these kind of symptoms. And he found that people who were eating these type of smoked sausages had lots of different symptoms: dry mouth, intestinal problems, pupil issues, ptosis, diplopia. And he theorized that this was coming from a toxin made by bacteria, not the bacteria itself, which is really, really interesting because he did not have the technology to really know these things. This was all things that he was guessing. Here's a couple of different points from him talking about these things. He said the nerve conduction is brought by the toxin into a condition in which its influence on the chemical process of life is interrupted. And I really like this next line. The capacity of nerve conduction is interrupted by the toxin in the same way as in an electrical conductor by rust. Very well-spoken German gentleman. And then really interestingly, what this guy talked about was that he concluded that if you applied this toxin in small doses, it should be able to be used medically for hyperactivity and hyperexcitability. So he was actually already talking about how this could be used clinically. We weren't able to use it for another, 160 years. Then there was an outbreak of this type of botulism in 1895 in Belgium. And a doctor isolated the bacteria from the smoked ham that people were eating, as well as from the autopsies. And he found that this bacteria was causing it. This is Clostridium botulinum, which is the bacteria that makes this toxin. And Clostridium botulinum is an anaerobic, meaning it doesn't need oxygen to grow, rod-shaped bacteria. And this can be found in, now we know, in these outbreaks of this type of botulism outbreaks. I'm almost done with this, I promise. We'll get to some pictures in a minute. In the 40s and 50s, investigations throughout the US and in Europe showed that the way that botulinum toxin works is by irreversibly inhibiting the release of this acetylcholine, like we talked about earlier. This is a picture of a rat diaphragm that they were doing experiments with in the 40s in London. I do have a little bit of connection to this. I did my residency in San Francisco. One of my professors in San Francisco was a gentleman named Alan Scott. He was the first person in the United States to actually investigate the use of botulinum toxin in monkeys and then in humans. I got a couple anecdotes about him in a minute, but I do feel a connection to some of these things we're talking about because I got to see his research lab in San Francisco when I was a resident. But he is a pediatric ophthalmologist and was a researcher where I did my residency. And he had a lab in his garage in San Francisco in the 60s and 70s with monkeys. And he had a way that he would go and induce strabismus in these monkeys. And then he was working on various compounds to see if he could figure out a way to treat strabismus medically rather than surgically. And so he started looking for different compounds, and him with a couple other colleagues started looking at these rhesus monkeys to figure out what they were going to do. This is a slide from one of his original papers. He would inject botulinum toxin, or what he called it oculinum at that time, for lining up your oculi, your eyes. And he was able to do that in the extraocular muscles of these monkeys to actually correct some of their strabismus. He has all these slides of these monkeys in his garage. It was really interesting as a resident to get to see. One of the craziest things that I learned about him when I was there, and you guys don't have to read all of this, but at the time that he was doing this, there was very little antitoxin to botulism, and that was because there was only an animal-derived antitoxin at that time. So therefore, as part of his investigations, and before he was able to inject this into humans, the FDA made him think of a way to create a human-derived antitoxin. And being a researcher at this time, he decided the way to make an antitoxin for botulinum was to actually inject himself with higher and higher doses of the stuff. So for many, many years, his serum was the antitoxin for the country for botulism, for botulinum toxin overdoses of things, which is really, really interesting, but he's a really nice guy. These are some of the pictures from one of his papers. I had the good fortune of working with him in clinic a couple times, and the way that he would inject this botulinum toxin into extraocular muscles was he actually connected EMG leads to metal needles, you can see in this picture. So he would actually put a drop of tetracaine on the patient's eyes, have the patient look forward, have some of what he called oculinum in his syringe, and would move the needle into where he thought the muscle was going to be. The way he could tell he was in the muscles, he could start to hear the whoosh of the pulsations of the heartbeat going through the muscle. And that's when he would know how to do the injections. So really, really interesting guy and really, really interesting investigator, but really did a good job of figuring out a non-surgical way to treat some of these strabismus patients. And then just, I promise we're gonna get to some more interesting pictures in a minute, but in the 80s, he and other physicians noted that when they were injecting this oculinum for spastic conditions, that some of the wrinkles in these areas became less distinct. And he started sharing this stuff with some of his friends and co-researchers. Some people who needed to fix some facial asymmetry after a facelift. There was the Carruthers, were a couple in Western Canada who started talking about the cosmetic benefits of this. And then in 1989, after lots and lots of work, the FDA approved botulinum toxin for medical purposes. And that same year, Dr. Scott sold all of his financial interests in the manufacture of the toxin. He sold it to Allergan, which is crazy. And he's a really funny guy. He sold the rights to Botox for $100,000, which is crazy when you think about how much it's worth now. But he has some funny quotes. I remembered these, and I asked some of my co-residents about these. He said one time, I had my house paid off, my kids were educated, and I had the satisfaction of seeing absolutely wonderful medical results. So I was satisfied without the money. One of the other things he said was, I'm not terribly good at giving away and spending money anyway, so I didn't need any more. My favorite quote, which I remember from one of the talks I heard him give in San Francisco when I was there, he said he was happy when he sold the rights to the toxin because the FDA was really causing a lot of difficulties for him. Though he wishes he might still have a little piece of it at this time. He said a little piece of the pie. He joked that life would definitely be different at this point. He said he would maybe be on to owning his third or fourth boat and maybe even on to a second or third wife. He said that in front of his wife, which was really fun. But he's a really, really good guy. So, all right, let's talk a little bit more clinical stuff here. Now we know that there are actually 4 distinct subtypes of this bacteria, and we discovered this through outbreaks and research, but now we also know there are 7 distinct types of toxin. The reason this matters is the only type we use clinically is variations of the toxin type A, which comes from it. The toxin type B is marketed as well as Myoblock, which is a different brand of botulinum toxin like Coke versus Pepsi. We'll talk more about that in a little while as well. So that was enough of the history. Sorry for boring you guys with that stuff, but I think it's kind of an interesting introduction to our thinking about how this works. So now we're going to talk about these different formulations of things. If I can make this keep moving, perfect. Interestingly, the way that we think about botulinum toxin, the way it's packaged now commercially, is it comes in units. It comes as a freeze-dried solution that we reconstitute in the office, and we dilute it with certain amounts of non-preserved saline, and then we inject it into patients for medical reasons. Now, the units for botulinum toxin are called mouse units. That's actually what they are. And 1 mouse unit is the LD50 for a mouse, or what that means, it's the amount of substance required to kill 50% of a test population. So kind of morbid stuff. But so the LD50 for humans is 2,800 mouse units. And botulinum toxin typically comes packaged in either 50 or 100 unit vials. So you have to inject a whole lot of this toxin stuff before it becomes something that's toxic for people in a negative way. So for a 70 kilogram adult, that's a whole lot of stuff that you have to use. And then 1 microgram of this toxin could be fatal if it's ingested or inhaled. So you know a much higher dose if you're gonna have the toxicity from this. So even now there's outbreaks of botulism, and what these people are getting are huge doses of this toxin that we use in much smaller doses clinically. For most facial injections that we do, for functional, meaning medically necessary, or cosmetic applications, these require somewhere in the realm of 25 to 100 units per injection episode. So much, much smaller doses than anything that we have to be concerned about medically. And then it's charged either through the insurance for medical purposes or for cosmetic purposes. It's charged by the unit that we do for the injections. So it's actually billed for how much you use, not necessarily for the injection that you're doing itself. And that it depends on where you are and the part of the country and what you're injecting it for, but typically it's somewhere in the realm of 10 to 16 bucks per unit. So if you're getting, 25 units, you're spending at least $250, $300, $400 for those kind of things. That is billed through insurance for medical purposes, and we'll talk more about that in just a few minutes. I'm going to talk about the different brands that are commercially available very quickly, and then we'll get to some clinical stuff. But Botox is the oldest and most known of these toxins. And again, this is sort of has become the name of all of these botulinum toxins because this is what people are used to seeing. It still has most of the market share and very well advertised on TV and in print and on the internet, and has over 10 times the market share of their competitors. And in 2018, Allergan reported $3.6 billion in sales from Toxin. That's a third of the revenue of their whole company. And remember, Dr. Scott sold it for $100,000 bucks. So again, he still likes that decision, but life would be a little bit different for him these days. And like I said earlier, this comes as 100 or 50 unit vials, and it can come as therapeutic, which means medically indicated, or cosmetic. It's actually the same formulation of the stuff. They just market it differently and have 2 different parts of their company who market these things differently for medical or cosmetic purposes, even though the compound is identical. And like I said earlier, the toxin must be reconstituted before we inject it. Other brands of this, they all have slightly different molecules of the toxin, and they all have slightly different approved indications. And we'll talk a little bit about that, but that's getting into the weeds a little bit. But I mentioned Myoblock earlier, and that's a different type of toxin. It's a B versus A. It was the next FDA approved toxin in 2000. It has a couple of clinical indications these days, but it's become less and less popular for these reasons. It has shorter duration of action. It diffuses into larger areas, so it's harder to control where the injections go. And the injections tend to be more painful. So for all those reasons, it's very rarely used. It's been years since I've used Myoblock in patients. Dysport is another type of toxin. It's a toxin type A. This was approved in 2009. Very good. It tends to spread more than Botox, and so patients have to be aware of that. I don't use this much clinically because the areas we're injecting, especially for medical purposes, we do not want this to spread into the eyelids further than where it is or into the orbits and cause some complications. We'll talk a little bit about that in just a few minutes. Xeomin is a very common used type of this toxin. It was FDA approved in 2010. The idea behind it is it's manufactured to have a smaller molecule than the Botox toxin. The thought is that it has less chance of an immune reaction. There's not really been much data to show that. And it's about the same strength as Botox. It's a slightly bit stronger, so you have to be careful if you're using this rather than Botox. It is a little bit cheaper to get and to reconstitute, so that's why it's become more popular. And sometimes insurance companies dictate that we use this versus Botox because it costs them less money to use. And then Jeuveau is the newest of these. It was approved last year. It's also a toxin type A. It only has cosmetic indications. There's no medical indication for it. The company is hoping to make some more money in the coming years, but launching a product right before a pandemic has not done very well for them. So I haven't used this very much, but it's supposed to be good. And the hope is that it'll be a little bit more affordable for patients. So, all right, we talked about all that stuff. Now let's talk about these medical indications of botulinum toxin. And there's a lot of these, and Botox is getting more and more of these things approved all the time. I'm gonna focus specifically on the ones around the eyelids and the face, but I'm gonna show you these real quick. Treatment of urinary incontinence, treatment of headaches. We'll talk about migraines in just a minute, just quickly. Spasticity, cervical dystonia, hyperhidrosis, which is excessive sweating, blepharospasm, that's where we sort of fit in here, and then strabismus in patients greater than 12 years of age. It's one of the interesting things about all these different indications is we're using a very small amount of this toxin around the face. For things like spasticity in the limbs and things like that, some patients are getting hundreds of units at a time of these injections. And 20 or 30 years ago, people thought that was going to be a really bad thing, but kids with cerebral palsy, patients with muscle contractures, these large amounts of these injections can be really, really helpful at relaxing some of their muscles. I get a lot of patients about Botox for chronic pain and migraines. I don't know if you guys have seen these or have any patients from questions, but this was the relatively new indication that came in 2000. And it was an idea that patients who were getting these cosmetic injections also reported relief from chronic headaches. And the thought originally was this was happening from a laxing of muscles, but we now know that it actually inhibits the release of pain neurotransmitters. And so it suppresses headaches from ever starting. Usually for these types of things, there's protocols that are 150 to 180 units used per injection treatment, or for treatment for these kind of things. Botox takes about 2 to 7 days to kick in. Once it's there, it takes about 14 days to have the full clinical activity of what you're doing. And then for the facial striated muscles that we use for blepharospasm and hemifacial spasm, this usually lasts about 3 to 4 months. Whereas for autonomic nerves, it lasts somewhere in the realm of 6 to 9 months. And the interesting thing about this is Botox does not get washed out of the system. Once it irreversibly binds to those neuromuscular junctions, it never goes away. Instead, the body sprouts new nerve terminals, and that's how the effect wears off over time. So your body is actually moving around the botulinum toxin to create these new nerve terminals, and that's why it wears off over this short amount of time. There are lots of complications that can happen. Luckily, these are rare, but they are things that happen, and you may have seen some of these in your practice. You can get bruising from the injection sites itself. You can be under or overcorrected. Facial asymmetries from these things, paralysis of nearby muscles. We'll talk about some of these things in just a few minutes. Generalized weakness, loss of muscle tone with lots and lots of injections, flu-like syndrome, nausea, headaches, lots of different things. This is the main crux of why I wanted to give this discussion tonight is I think because this is such a common thing that is happening in our society and with medical and cosmetic purposes, a lot of times patients don't even think of this as a medicine that they're using. They just think of it as like a cosmetic treatment for things. And so sometimes patients can come in with complications that the eye care provider is going to see. And without knowing that these things exist, sometimes we can do much more expensive and much more extensive workups for things that may be as a result of the injections versus another medical problem. So ptosis can happen with any injection around the periocular tissues, and this because that toxin can migrate into and weaken the levator muscle. There can be ectropion or entropion. This typically happens in older patients who already have some weakness of their orbicularis muscle fibers. I saw a patient a couple of weeks ago who had a very bad entropion from another provider doing a Botox injection around the patient's eyelids. And it's because it basically relaxed the muscles that were keeping the tone of the orbicularis that was keeping that eyelid in the normal position. Lagophthalmus can happen from weakness of the orbicularis muscle. Brow ptosis can happen from injections across the forehead. This can actually make lids look heavier, can look ptosis look heavier, can look dermatochalasis of the skin of the upper eyelids look heavier. So it's good to, if you have these things that you're seeing in a patient, you haven't seen these things before, ask if they've had these injections because it can help delineate the underlying cause of why these things are happening. And then one of the other noticeable things that we see sometimes is diplopia, and that's because this toxin can actually migrate into the extraocular muscles and can cause diplopia and double vision from relaxing those extraocular muscles. Now, the good thing about this is all these things are temporary. They typically wear off in 2 to 4 months, which is not a very fun 2 to 4 months for the patient to have to live with this, but you can reassure patients that almost always these things wear off. They just have to be patient. And so if any of these patients come through and you see these kind of things, it's always good to ask if they've had a recent injection for either medical or cosmetic purposes. And then a couple other contraindications. I don't inject, and you're not supposed to inject in patients who are pregnant or nursing, or if they have specific allergies, or if they have other neuromuscular issues like myasthenia gravis or Lou Gehrig's disease. Now, another interesting thing that I've noticed in the last years of my practice is there are lots and lots of different providers doing these injections. Ophthalmology, oculoplastics, and neurology are the docs that inject most of these toxins for medical purposes. But ENT, dermatology, plastic surgery, et cetera, do a lot of these things for cosmetic purposes and some medical purposes as well. Dentists are injecting botulinum toxin into the masseter muscles for TMJ. I have a friend who goes to her dentist for her dental cleaning and also gets gas while she gets her cosmetic botulinum toxin injections. Family practice doctors are doing this. There's lots of med spas, nurse injectors. Some states have optometrists doing these kind of things. So it's a very common thing that you're going to see no matter what kind of practice that you have. And some injectors are better than others. People know the anatomy in certain places. Certain specialties know the anatomy better and can try to minimize some of these complications. And the other reason it matters who's doing these injections is that botulinum toxin injections can lose their effect if they're injected too frequently. So if you're injecting them every couple of weeks or every month to try to make something perfect, you can have actually sensitization and antibody production, and this makes the botulinum toxin less effective over time. I run into this sometimes if patients have sort of doctor shopping and will have injections someplace and not tell you the truth about where they've had the injections before. And unfortunately, if they get these injections too often, it just doesn't work for them anymore. So that's why we try to delay our injections as long as we can, somewhere in the realm of 2 to 4 months before we repeat these things. And so we can make them continue to work for patients. Sometimes if you inject for a long period of time, you can weaken some of the muscles and make these problems patients have less noticeable as far as the twitches and the cosmetic concerns. But these injections are not cures for these diseases we're going to talk about. They're just helpful treatments that last 2 to 4 months. All right, we're going to talk about each of these things that we'll see in an eye practice that can cause some twitching around the eyelids. That sometimes there's some medical indications we can treat these things. So this first video, and I hope this comes through, this is a patient who came to the office and actually was seen for something different, but I want you to notice the little twitching that you see along his lower eyelid right through here. This is myokymia. This is the name given to the condition characterized by this mild, intermittent, isolated twitching of the muscles around one or both eyes. I'm gonna play that again. A lot of us have had this before. It's annoying. It's not really a terrible medical problem. Usually it happens in patients who have lack of or disrupted sleep, stressful periods of life, excessive caffeine intake. Very rarely does this become medically necessary to inject, though I do have a few patients that come in every few months and we inject very, very small amounts of botulinum toxin. These people, we're talking somewhere in 2 to 4 units right in the middle part of their orbicularis, their lower lid. By doing that, we can relax these muscles so they're less annoying for people. So that is an indication, but it's a rare indication in my practice because usually this is intermittent and it's typically not a terribly bothersome thing for people. Next, we're going to talk about benign essential blepharospasm. I bet most of you have seen a patient with this over time. And this is a condition where there's contraction, uncontrolled contraction of the eyelid muscles around both of the eyes. Typically, it progresses from an occasional minor nuisance to a really constant and uncontrollable inability to stop these spasms. It can also happen around patients' mouths. If that happens, it's also called Nage syndrome. The underlying cause of this, we don't really understand, but the first line therapy for this is botulinum toxin. It can greatly reduce these symptoms in patients, in about 90% of patients. These injections, like I said, last 2 to 4 months, and then we have to treat them again. So this is a patient before. For all of my patients, I have a treatment map that we use in our EMR to actually show where we do these injections. The treatment pattern we do is slightly different for each patient, depending on the type of spasms that they have and other symptoms that's going on. This is a very common pattern we see for benign essential blepharospasm, where I use this little map and we're injecting 5 units into all these areas. And this is specific for this patient. And then after those injections, she still has some twitching around her eyelids, but you can see it's much more controllable for her. So prior to these injections, she couldn't, she said she wasn't comfortable driving. She said she had people staring at her all the time. She wasn't able to read or watch TV. So by giving her these injections, she said it's been a great benefit for her. So that can be really useful for folks. The next thing we're going to talk about is hemifacial spasm. This is a video a patient sent to me showing these types of spasm. And unlike benign essential blepharospasm, as it's called, hemifacial spasm just happens on one side of the face. This is caused typically by an abnormality along the course of the facial nerve. And that's the nerve that connects the brain to the muscles of the face. Sometimes neuroimaging is necessary for these people to rule out any masses or space occupying lesions. Interestingly, this is present even when patients are sleeping. Benign essential blepharospasm is not there on both sides while they're sleeping, but this is actually there while they're sleeping. And for most patients, short of a neurosurgery, botulinum toxin injections are the first line therapy for these people. And you can get control of their symptoms in 80 to 85% of people. I did do injections on her and I took a little video of it. If anybody's squeamish with a little look of a needle, you can turn away for just a minute. It's not bloody or gory, I promise. But for this patient, we did injections into the right underneath the skin and just in the areas where she had most of the spasm. One of the really interesting things that I find for these patients is you can do these small amounts of these injections around the eyelids, and sometimes that is enough to keep even the spasms of their cheek and perioral areas under control. I've done injections for this patient a number of times, and I only inject around her eyelids. I don't inject around her cheeks because occasionally she gets a little bit of a droopy mouth and has trouble swallowing or drinking out of a straw, not swallowing, drinking out of a straw on that side. So we did these injections for her, and then you remember what her twitching looked like ahead of time, and this is what we look like now, and you can see it's much more controlled for her. So again, this patient had a lot of difficulties with driving and reading and watching TV and doing her normal activities of daily living, and after these injections, it made a big, big help for her. So those are the main reasons that I see these people for medical purposes. It's interesting, a lot of times patients will not, these things exist and they exist for years before patients realize that something can be done for them. I have a lot of patients that come and see me for the first time and think, man, I wish I would have known about this kind of stuff years ago because this has really been a bother for me. I also have patients that are referred for me for these types of spasms and it really doesn't bother them because they've been there for a long period of time. And under those circumstances, we talk about the treatment options, but you don't have to inject them. Most patients really like the injections from these things because it makes their lives much easier. Now, even though botulinum toxin is the first line treatment for these conditions, there are other treatments that can be done as well. There are some oral medications that can be used. These are typically sedative medications. And so these have limited clinical activity for these folks, but some patients can use these as an adjunct to the injections. And there are also surgeries that can be done. In the days before botulinum toxin, if a patient had very, very significant benign essential blepharospasm, that's the BEB here, a surgical procedure was performed called a myectomy. And that actually required extensive excision of all of the periocular orbicularis muscle. It's a very, very tedious, very difficult surgery and was not a cure for these folks. And basically you're cutting out all of the muscles that close their eyes. These people had all sorts of complications. Botulinum toxin is a much better treatment. I still have a few patients and elderly patients who had these types of surgeries years ago, and they're still needing injections 20, 30 years later after those kinds of surgeries. And then I mentioned briefly earlier that neurosurgery can be done in certain patients with hemifacial spasm, but typically the risks of that surgery outweigh the benefit of doing anything of the hemifacial spasm. All right, enough of those medical indications. Let's finish up really quickly about some cosmetic indications for botulinum toxin. This is where most of the money for botulinum toxin is made for the company. In my practice, I do a fair number of medical injections as well as a fair number of cosmetic injections for these things. I think injection with botulinum toxin is a very fun, easy treatment for a lot of folks. There's a lot of cosmetic indications for Botox branded stuff as well. And there's 3 main ones. And then we're going to talk about a couple of areas that are off label in just a few minutes. But the first indication for cosmetic purposes was the glabella, which is the 11 lines, which is the area between the eyebrows. I'll show you some pictures and videos of that in just a minute. And that was approved in 2002. 2013, the approval was done for the lateral canthal lines, or the crow's feet towards the outside corners of the eyelids. We'll show you some of that in a minute. And the newest indication was in 2017 for forehead wrinkles. Now, the other botulinum toxins we're talking about do not have all of these indications, but depending on what you have in your clinic, where you are in the country, there's a lot of people will use a lot of these toxins interchangeably for these different reasons. I mentioned to you there's those 3 indications from the FDA. One is the 11 lines. So this is the glabella, the tissues between the brows. Some people have 11 lines. Some people have 111 lines. This patient has 1,111 lines from all those little lines from the corrugator muscles. There's an indication for the forehead, and there's an indication for the crow's feet in the outside corners of the eyelids. But on the lower face, in the lips, perioral lines or smoker's lines, neck lines, frown lines, and other places, there's a lot of different areas where this toxin can be injected for medical purpose, or excuse me, for cosmetic purposes. I'm going to show you just a couple patients that we did some cosmetic injections for. This is a young patient. You can tell this was done not too long ago because, of course, she's wearing her mask. She came in and did not like the angry mommy look, as she described it. And so I have patients take pictures. I take pictures of them beforehand to show the areas that they want to improve upon. So she did not like these 11 lines here. This is with her scrunching down or giving me her angry mommy face. And this is her raising up her eyebrows. And she also didn't like the appearance of these wrinkles across her forehead. So this next slide is a video of the injections that I did for her. And I'll explain this in a little bit of detail. There's another couple of needle pokes. So if you're not too much blood and guts, but if you're a little squeamish, you can turn away. But what I'm doing is injecting a certain amount of medication into the muscles. These are the corrugator muscles that form these little lines. As I mentioned earlier, the botulinum toxin comes as a freeze-dried crystal, and you reconstitute it by injecting it with saline. And then depending on where the muscles are, you can inject these with small amounts of botulinum toxin. You dilute it in a certain way so that we know how much we're injecting in these spots. So for her, I injected along the corrugators in the middle. We inject a little bit in the outside corner. We get a little bit of brow lifting from doing that in the outside corner. And then I actually have the patient animate in the office. And you can see that I'm injecting in the areas where this frontalis or forehead musculature is. For this patient, what we're injecting with is a 30 gauge needle. There's no numbing done for her. We do have some numbing creams that we can use ahead of time if patients desire them. But for most folks, these injections are very comfortable in the office without much difficulties. And you see, I'm actually having her animate so we can see where things are moving in the office. And that's typically what you have. Little bee stings, look like little red bumps for a few minutes after we're done. There's no limitations in patients' activities after we do these kind of things. So that's where we did the injections for her. And then here is before. Sorry, these aren't lined up perfectly, but this is her before and after without her animating her face at all. And like I said, we get a little bit of a brow lift by doing things in the outside corner for some patients. You can see that those brows are more arched in the higher position. More importantly, this is that angry mommy face with those 11 lines. You can see here, we can notice those lines across. For here, they're much softer. And this is with her grimacing down. More importantly, on the forehead, this is with her lifting things up. She had these lines before that she wasn't a fan of. We were able to smooth that out with her lifting up her forehead. I'm not a big fan of the overdone look for these patients. I find that patients who have too much of this and can't animate their face at all look very strange. And you can look at them on TV or in movies or walk through the grocery store and you can say something is wrong with those folks when we're looking at them. That is not at all my desire. And I have that discussion with patients ahead of time that their expectations of what we're doing need to be reasonable. But it is really fun in the office, and we see these patients first back a week or two later, and we can see the difference in the movements of their face. Here's another patient that came to the office. Again, she did not, these are not the most distinct 11 lines, but she did not like the look of her grimacing down. This is, again, the glabellar area. She did not have many wrinkles across her forehead, but she did have these crow's feet that she did not like in the corners. So for her, I actually had her animate. I told her I was doing this and was going to use it for a presentation, but I actually had her animate in the office. Those are those 11 lines that she did not like the appearance of. And then when she smiles, she's got all those little wrinkles in the corners, which she did not like looking at. And then again, we have her grimacing down in the middle here. For her, we did the injections. Here's me doing the injections in the office. I actually have the patient animate so I can see where I'm doing these injections. Again, this is the 30 gauge needle. Usually I'm injecting somewhere in the realm of 5 to 10 units for each of these injection sites, depending on what we're doing, and depending on how strong the muscles are. So that was the one that was helping with the glabella. And these are the injections that are helping with the crow's feet in the corner. You can see there's just a little wheal right underneath the skin surface there where this stuff starts to build up. Patients won't notice an improvement immediately. She was funny. She asked to look at the video and she said, I just wanted to make sure that I wasn't looking too much like a wimp when you were doing the injections, which I thought was funny. But she did really, really well with these little injections. I won't show you the rest of this. Let's go to the next slide. Here's what she looks like after. Go to the next slide here. There we go. Next slide. Here we go. All right. This is what she looked like afterwards. So if you remember what she looked like before, when she was scrunching down her forehead muscles here, her corrugator muscles, she had these lines. This is when I asked her to do the same thing. And you can see her trying to scrunch those down. You can't notice those wrinkles in those spots. And then when she's smiling in the corners, you can see that those lines are much more relaxed. And that's helping with those crow's feet that we talked about. And I've got some still pictures of her too. This was her before with her scrunching down. This is her after with her not scrunching down. So, I mean, this is also trying to scrunch down those forehead muscles. And you can see that those lines have relaxed. And then crow's feet in the corners, this is what she was happiest with. We can see where those crow's feet really softened up with her smiles. There has been a trend to do botulinum toxin in younger and younger patients for cosmetic purposes. Some of that is excessive, absolutely. But there is some utility in treating folks with when they start to have some of these wrinkles that show up. They don't like the appearance of them because you can soften them over time. Once you have very, very deep set wrinkles that have been worked on for a number of years, it's actually very difficult to relax those things away. Sometimes we actually have to use fillers, cosmetic fillers. That's a topic for a different day. You know, anybody in their 30s and 40s and beyond who have lines that they don't like around these areas of their face, it starts to be very reasonable for us to do these things cosmetically. Another last patient I have here, this is one of my good friends who I've been giving injections to for a number of years. This was also what she called her angry mommy face. And she said she liked to get injections in these little areas. This is her scrunching down. This is her trying to do it 2 weeks after I've done the injection. And she said she liked this because she could hide she could hide her disgust with her children when she was having these injections. They didn't know when she was mad at them, and she liked that aspect of things. So that's all of my talk. I left a bit of time here for questions about these kind of things. There's my 3 kiddos. I got Anna, a 9-year-old, Nathan, a 6-year-old, and that's Amelia, my 3-year-old. That's my world these days. Luckily, my 2 older kids have gotten to start going back to live school this last week. And life's a little bit more normal in my house. And now they're coming home exhausted from school because they haven't been in school for months and months and months. But it's really fun to have everything moving for them. And then again, here's my email address. I didn't put my cell phone number on here, but it's on there. And if I'm open for questions, if anybody has any questions about this topic or anything else I can be helpful with. Let me see how I get out of this. And let me stop my screen share. And then, all right, here we go. Good questions from all these here. Perfect. All right, first question I see, there's a question on here. Would this work on reflex sympathetic dystrophy, complex regional pain syndrome? The answer to that is there's a lot of research going into those things right now for chronic pain patients. As I mentioned earlier, the injections for these, it was sort of a side effect that came from injecting for cosmetic purposes. And again, the thought was that injection with these chemicals reduces the neurotransmitter of pain nerves. So there's more and more research going into these kind of things. And some pain doctors, neurologists or pain doctors and anesthesiologists are doing more research into these things. The only indication I know FDA approved at this point is for chronic headaches and migraines, but there's research going into this all the time. It's sort of the wonder drug, and people keep coming up with more and more indications for these things. Interestingly, patients who get this for excessive sweating or other things, they're getting 100 to 200 units in injection at a time. And again, 20, 30 years ago, people thought that was crazy, but now we know that it's safe in controlled injectors' hands, and so it becomes a very more common thing that we can see. Next, very good questions. I got a couple more questions here. How often does a patient need to come in to be injected with Botox? Every patient's a little bit different. For medical purposes, I have patients that require injections every 6 weeks. I have some that require them every 6 months. Most folks, it's in the realm of 3 to 4 months. At about 3 months, the injections typically start to wear off. So once I've done injections a few times and I'm very comfortable injecting certain patients, they are able to tell me when the spasms start to come back. And right when they start to come back is when we want to do the injections, because we don't want them to be debilitated by the amount of their twitching. And then the very, very important question I was just asked was if I thought that Dr. Moyes would be better looking with a little bit of botulinum toxin. And I won't say who asked that question. I won't say who asked that question. And my job is never to judge anybody. It's just to offer my suggestions for them. The funny, my original thoughts about this talk was that I had a lot of patients who are referring doctors who asked me questions about this, and I actually wanted to do a live injection at one of our OD events. And I was going to ask for volunteers from any helpful referring doctors or any staff or anything else that we could do it in front of folks. But obviously the COVID has messed that up. But I'm happy to answer questions about these things. I get selfies from my friends saying, "Do I need Botox yet?" That's one of the things that I see all the time. Yeah, Dr. Moyes is giving me the angry mom face right now, so that's perfect. But thank you all for listening. Please email me or text me with any questions if I can be useful anytime. Thank you for spending your time with us, and hopefully we'll all be able to get to see each other in person in the near future. But we really appreciate your time tonight. We really appreciate you guys tuning in. Lindsey's still on here too. I think if anybody thought of any pressing glaucoma questions, we're around here if we can answer anything for a few minutes.
Hey, Michael, I did have one question for
Great.
you, kind of back in the direction of one of our optometric colleagues that had talked to us today.
Yeah.
Just about binocular vision type issues that might be associated with Botox.
Yeah, it's it can be very concerning when patients come in. I mean, no one loves seeing those double vision patients walk in the door on a Friday afternoon. And there's lots of different reasons that a ptosis or a sudden onset ptosis, sudden onset double vision, inability to close the eyes, all these things happen for a number of different reasons. And it's important to ask folks if they've had these types of injections. And you'd be amazed how many people have had these things. And again, don't even think about it as a medicine or something they need to even report to their doctors. If a patient has a new onset, you can't always say that the botulinum toxin is what's causing some of these more concerning things like a new onset diplopia, but you have to put that in the discussion and ask them about it. The question we had earlier was a patient has had some strange diplopia for a number of months. And if they had a botulinum toxin injection that is causing this, that should be washed out of their system in a maximum of 3 to 6 months. So if one of these things lasts a lot longer of a time period than that, then you can't really attribute it to these things. Usually, if you get one of these negative side effects from these injections, they typically wear off in the near future. And as we all know, if you have a new onset diplopia, people's brains don't like that stuff. And I've had a few patients that I've seen where the diplopia actually can wear off even quicker than the other function of the Botox. So it may return even more quickly from those kind of things. But it's definitely a good thing to ask patients. It's definitely a good thing to pay attention to. And dovetailing a little bit, it's really interesting all the different uses that people are having for botulinum toxin. I've had a couple patients in the last year who have come in with very significant exposure issues, either from a stroke or a Bell's palsy, and were not good surgical candidates. And we talk about all the different options of protecting those eyes, taping and frequent lubrication. Putting 10 units of Botox into someone's levator muscle centrally can also give you a 3-month temporary tarsorrhaphy for some of these people. I've had a couple patients who we've really helped them out by doing a quick injection in the office. It does not solve their problem ultimately, but you can do a great cornea exam because all you gotta do is lift up the eyelid. You don't have to, cut through stitches or a tarsorrhaphy, anything along those lines. It's not the first line therapy for these things, but there's lots of creative and useful ways of using this kind of stuff in capable hands that can really help out with some of these situations. So that was a long answer to your question, Dr. Gelman. But
No, that's great. Thanks for addressing it.
Of course. Great turnout tonight. Thank you all for being part of this. We obviously miss seeing everyone in person, but I guess chatting through Zoom is the new normal for things. So my 9-year-old daughter, Anna, calls the time before COVID in the before. So hopefully we'll get back to what we can do from in the before when we used to have these things in person in our office. So great. Thank you all for listening tonight. We really appreciate you guys tuning in. Cami I talked to her a few minutes ago, and she said that there should be certificates for your continuing education by the end of next week. Again, if you have any questions, please reach out to any of us. There's questions about the lectures tonight. Cami is super helpful with these kind of things. We really appreciate your attendance, and everybody stay safe and let us know how we can help moving forward. Thank you so much.
Dr. McDaniel,
Yes,
can you hear me?
I
Hey, I
can.
sent your question in the chat.
Yeah, I
I'm
just
Dr.
saw that.
I'm Dr. Gosnell, and I'm in South Dakota.
Nice to see you.
It's good to see you.
Um,
Hey, I used to practice in Kansas City, and now I'm with the Indian Health Service
okay,
in
okay.
Pine Ridge near the Black Hills.
Yeah,
And I missed almost all of your talk because I was having trouble getting on Zoom.
no worries.
But I'm having trouble finding good laboratory testing for VKH, and I have more than 12% of my population that have between 5 and 7 of the actual symptoms or part of the syndrome for the VKH. So they have alopecia,
Mhm.
tinnitus, stiffness in the neck, vitiligo, anterior, posterior, panuveitis, secondary glaucoma, and that's where you come in. So I was just wondering if there were better tests with more specific antigens than HLA, B22, B27, DR4, those kinds of things. And I can't get anybody to do those tests up here.
I don't know of any. I don't see a ton of that here. I did a rotation, so I was a couple months down at the University of Florida, and we saw a couple. I don't think they were more screening symptomatically. They weren't doing any routines. This was a couple of years ago, so there may be something newer. But in the past probably 5 years, I don't know that I have seen a case of that here. So I wish I could give you more information, but I don't have a specific test that would be better for that. And I haven't ordered those for that specific issue. So I'm probably not the best resource, unfortunately, for that.
It's okay. I appreciate your time and attention. Thank you very much.
Absolutely. If I hear of anything, though, I'll certainly pass it your way.
That'd be great. Thank you.
Absolutely. All right. Thanks for participating, everybody.